Good afternoon, ladies and gentlemen, and welcome to speaker and guest to this session dedicated to adolescent gynecology. I would firstly like to thank Professor Gynecology for having included adolescent gynecology among the ISGE webinars. As you know, adolescent gynecology is an area of special interest in gynecology and endocrinology and encompasses a wide spectrum of conditions affecting gynecological health of girls. But we must focus on a sensitive and timely approach to ensure optimal reproductive health and fertility into adulthood. And this afternoon, Professor Genazzani has chosen two main topics in adolescent gynecology. The first one is adolescent dysmenorrhea and endometriosis, which will be, this lecture will be given by Dr. Laura Gaspari. And the second is dealing with contraception in the adolescent by Professor Celis González from Mexico. Dr. Laura Gaspari is a pediatric endocrinologist who has been trained in Montpellier University Hospital in both fields of pediatric endocrinology as well as adolescent gynecology. She has contributed to many original work and review, and it's a pleasure to welcome her to talk about interesting, very common topic in our field, adolescent dysmenorrhea and endometriosis. Laura.
Good morning, dear colleagues. I want to thank Professor Genazzani to have organized this beautiful meeting and to have invited me to share with you this our experience, clinical experience. I will start the slides. I have, I'm sorry, I have no conflict of interest. And this is the outline of my topics. I'm sorry, I have some problem. Okay. Dysmenorrhea is defined as painful menstrual cramps of uterine origin that can be classified into two groups: primary dysmenorrhea without organic disease and secondary dysmenorrhea associated with organic pelvic pathology. Primary amenorrhea is thus defined as painful spasmodic cramping in the lower of the abdomen just before and or during menstruation, in absence of any discernible macroscopic pelvic pathology. The onset is between 6 and 24 months after menarche. It has a predictable temporal pattern. It starts just before and or during menstruation and lasts between 8 and 72 hours and may irradiate to back and things. It may be accompanied by systemic symptoms such as diarrhea and vomiting. Conversely, secondary dysmenorrhea is a dysmenorrhea which is linked to an organic pathology, such as ovarian cyst, pelvic inflammatory disease, outflow tract obstruction, Muller tract abnormalities, genital infection, leiomyoma, adenomyose, and in adolescent, moreover, endometriosis. The pain onset usually 2 years after menarche, more than 2 years after menarche. The cycle may be regular or irregular. We have to notice the pain will be exist also in non-menstruating phase of menstrual cycle. And there are many other symptoms associated, such as menorrhagia, intermenstrual bleeding, and so on. Dysmenorrhea, primary or secondary dysmenorrhea, is a very variable pathology. We may have systematic symptoms, headache, nausea, and so on, which occur absenteeism, reduction in physical activity, and stress, anxiety, psychological problem. We have to consider it as a syndrome with a huge effect of the quality of life of our adolescents. Regarding epidemiology, we have to say that dysmenorrhea is the most common gynecological condition about women of reproductive age, and particularly of adolescents. The prevalence of primary dysmenorrhea is highly underestimated, and this because few affected women seek medical treatment, because dysmenorrhea is considered as a normal part of menstrual cycle for ethnic and socio-cultural factor, and also because it's considered an unavoidable rite of passage. For these main reasons, and also because there are different definitions of dysmenorrhea, there are wide variation in the prevalence of it. It may range between 20 to 93%, with a severe primary dysmenorrhea, which range at between 10 to 25%. The more recent publication, epidemiological studies show an percentage of prevalence of 90% in Sweden, 73 in Russia, and 92 in France. To better quantify this syndrome and to also to perform a follow-up of these adolescent girls, we have developed some years ago a clinical scale that take care of all principal symptoms linked to dysmenorrhea, and with the different notes that are scored from 0 to 3. And we can separate dysmenorrhea into groups, moderate if we have more than 5 points, severe more than 9, and very severe more than 14. With this scale, in the south of France, the Professor Sultan group have performed an epidemiological study, which we found 21% of overall prevalence of adolescent dysmenorrhea, with 39% of family antecedent. And the same study performed 40 years later found 37% of severe dysmenorrhea. Regarding the etiology, we have to notice that there are some risk factors that we have to look for. And particularly, regarding medical history, we have to check the early age of menarche, menstrual disorder, clinically, abnormal body mass and normal abdominal adiposity in particular, an hyperestrogenism in biological examination. We can find stress, anxiety, depression, low social support, and the diet, the modern diets, such as snacks diet, are more likely linked to dysmenorrhea versus lacto-vegetarian and mixed food items diet. Regarding the cause of primary dysmenorrhea, it is not well established. However, the responsible cause has been identified on the hyperproduction of uterine prostaglandin, and particularly PGF2A and 2, which result in hypercontractibility of myometrium arterial vasoconstriction, endometrial ischemia, and dysmenorrhea. Prostaglandin production is controlled by progesterone. When progesterone level drops, immediately prior to menstruation, prostaglandin level increase. If the exposure of endometrium to luteal phase is crucial for the increased production of progesterone, dysmenorrhea occurs only with ovulatory cycles. This could explain why primary dysmenorrhea onset is shortly after menarche, and why dysmenorrhea also responds to ovulatory inhibition. However, there are other factors, and particularly the neuronal factor. In particular, I would like to say that recurrent menstrual pain will cause the changes, peripheral changes, which increase the sensitivity to pain, and central nervous system changes with pain-induced central activity, cerebral metabolism, and cerebral structure, which create a predisposition to chronic pain. And all these factors cause reduction of quality of life, sleep quality, reduction in physical activity, poor mood, and other comorbidity. Regarding treatment, we have to know that and to accept that many adolescents don't to seek help for this dysmenorrhea and are thus undertreated. About 50% they choose self-treatment, or they ask to their mother. And 30% of prescription drugs users may not be using it effectively. The empirical therapy for suspected primary dysmenorrhea repose on different levels. The first level therapy include non-steroidal anti-inflammatory drugs. We can use ibuprofen 400-600 milligrams every 6 hours. And usually we have a good control of dysmenorrhea. In other case, we can try hormonal therapy, estrogen, progesterone combined contraceptive, in a cyclic way or continuously. And after, we can use progesterone medication, where really effective, but there are some side effects, and other adjunctive therapies such as exercise at PEC, transcutaneous electric nerve stimulation, as well as acupuncture and other things like this. We would like to stress that the idea that we have to reevaluate the adolescent each 3, 4, 6 months, because in this way we can understand if our treatment works off or not. In the second case, we have to ask regarding the assessment to the treatment adherence. It's very important. We can do a pelvic examination if the adolescent agrees, or we have to do pelvic ultrasound and refer to a gynecologist. Also, the committee opinion confirmed the same flow chart with non-steroidal anti-inflammatory drugs, hormonal therapy, non-pharmacology strategies, which are very important, and a recent Cochrane review stressed the importance of exercise, smoking cessation, modification of diet, acupuncture, and please consider pelvic examination and moreover pelvic ultrasonography in order to look for pathology, ovarian pathology, pelvic pathology, such as endometriosis. Dysmenorrhea, could it be endometriosis? This wonderful work by Felicia Petraia was entitled, "Is primary dysmenorrhea a precursor of a future endometriosis development?" The answer is yes, because prostaglandin, which are the key of dysmenorrhea, as I told you, can induce the peripheral sensitization of the peripheral nerve, which are more sensitive to pain, a central sensitization with the central nervous system, which is which respond more to pain stimulus, the stress, which is following to this pain, which affect on hypothalamus axis, pituitary axis, which is the basis of chronic pelvic pain, which is the principal symptom of endometriosis. Donc, the question is now, is the menorrhea already endometriosis? As you can see here, the delay of diagnosis of endometriosis is really huge, and it may be last till 22 years after the start of symptoms. It has been referred endometriosis as the missed disease due to its unclear etiology and the inconsistencies in its diagnosis and management. And this is very sad. And particularly, it's very difficult to diagnose the endometriosis because of there are no specific symptoms, no specific biomarkers, lack of awareness by patient and doctors, and stigma or symptom normalization. Dysmenorrhea is the cardinal symptom of adolescent endometriosis, but as I told you before, is considered often as an unavoidable rite of passage. The pain in endometriosis may be cyclic or acyclic, with confounding symptoms such as dysuria, nausea, diarrhea. The pelvic pain is often chronic, and it may be peri or post-menarcheal. And please pay attention to non-cyclic dysmenorrhea, which is the most frequent symptom of adolescent endometriosis. Moreover, if it is resistant to non-steroidal treatment or OCP. Regarding epidemiology, between 25 to 73% of adolescents with chronic pelvic pain and dysmenorrhea present endometriosis, and 35% if dysmenorrhea is severe. I think that everybody knows the different pathophysiology theory regarding endometriosis, so I won't spend time regarding this, but I would like to stress on genetics, because we know that each patient, we have to ask to each patient the familiarity, because if the male present endometriosis, the daughter may have 8 times the risk or the ratio of 8 times to present endometriosis. And if it's the sister to present endometriosis, the risk increase to 11 times. In this huge work on the female monozygotes or dizygotes twin, you can see that 47 of risk factors are considered genetic risk factor, and the remaining 53% are attributed to an environmental effect. In particular, regarding environment, we have to look for prenatal or early events such as low birth weight, small for gestational age, Mullerian anomalies. And particularly, also neonatal uterine bleeding is a risk factor for early onset pelvic endometriosis, and in particular for a severe a progressive endometriosis. So we have to ask. We have also to ask the age at menarche, because the early menarche is a risk factor for endometriosis, and also evident dysmenorrhea, which starts 3 years after menarche. All the risk factors are the fetal exposure to endocrine disruptor, in particular distilbestrol. This meta-analysis showed that a prenatal exposition to distilben increase the risk ratio a little girls present 2 times the risk to develop endometriosis if her mother take distinct ban during pregnancy. And we show here in this huge family, we have written these articles some months ago, and we show that the mother take distinct ban to stop lactation after each deliveries. And as you can see, all daughters of the first generation, except the first, which is not exposed, presented endometriosis. All girls of the second generation present endometriosis when they were daughter of women presenting endometriosis. And the first girls who presented already menses as dysmenorrhea, very severe, that doesn't respond to usual treatment. Other endocrine disruptors linked to endometriosis are dioxin, PCB, bisphenol A, S, phthalate, and parabens. So we have to ask to our patient. Like a main key message is that persistent and or worsening cycles, cyclic or constant pelvic pain, particularly with the presence of other endometriosis-associated symptoms like nausea, etc. The familiarity history, the presence of systemic inflammatory immunological comorbidities, an abnormal finding of physical examination or ultrasound may suggest endometriosis. In this case, we have to perform ultrasound. And if it's inconclusive MRI, please don't dose serum biomarkers because they are not considered for diagnosis, and don't perform surgery to confirm endometriosis disease diagnosis because it is inappropriate. The medical treatment is the key treatment for endometriosis. It improves the painful symptomatology, block or at least reduce the disease progression, and protect future fertility. The patient and the family should accept the treatment, so they have to choose it according to the need of contraception, the contraindication to hormones, and the potential adverse effect. And particularly, ESHRE guidelines for endometriosis in adolescents and adults point out the necessity to start for combined hormonal contraceptive continuously or not. And we can use progestogen in like second intention treatment, and general agonist, antagonist, and aromatase inhibitor more like a third line treatment in adolescents. These are, here you can see the progestin only option, but we have to say that I prefer to use oral administration, to long time administration to stop therapy if the adolescent present side effects like weight gain, bloating, depression, or irregular bleeding. Moreover, progestin present in adolescents some limits. It reduces bone mineral density, which is only partially reversible after day suppression, which may interfere with the peak bone mineralization. So it's better to utilize OCP, first line treatment. In conclusion, the prevalence of dysmenorrhea is high, and its consequences are extensive on the duration, the reduction in quality of life. Recurrent menstrual pain not only is associated with central sensitization, but also may predispose women to primary dysmenorrhea and other chronic painful conditions such as endometriosis. We have to not to forget that 33% of adolescents with chronic pelvic pain and dysmenorrhea present endometriosis, and 15% if the dysmenorrhea is not cyclic and resistant to treatment by non-steroidal and OCP. Pelvic pain, if severic and non-cyclic, is the main symptom of endometriosis, and all doctors who take care of adolescents should put it in differential diagnosis to make early diagnosis. Endometriosis in adolescents is a high, progressive, and severe disease that deserves attention, not just compassion. Early diagnosis of this mixed disease may improve the painful symptomatology, the quality of life, block or reduce the disease progression, and protect the future fertility of adolescents. And thank you for your attention.
Thank you, Laura. You kept your time, so we're going to now move to the second topic, which is adolescent contraception. And as most of the participants of this webinar must be aware that adolescents have high rates of unintended pregnancy and high unmet need for contraception. Access to and effective use of contraception can be influenced by a variety of factors such as age, cultural norms, family consent, the attitude, socioeconomic status, level of education, national, ethnic origin, and so on. So you may have understood that adolescent contraception is a very important topic, and it's my pleasure to introduce the second speaker of this topic will be Professor Celis González. He's an OBGYN at the high specialized medical unit Luis Caterazano Ayala, which is a Mexican Institute of Health Service. Celis is a member of the executive committee of the Latin American Federation of OBGYN Society, FLASOG. He's also a member of the editorial board of the Menopausal Society Journal. And he's also, it's a big honor, it's a board member of the International Society of Gynecological Endocrinology. So, Professor González, please give your talk on the contraception in the adolescent.
Thank you very much, Professor Sultan, for this kind introduction, and it's a pleasure to share this webinar with Professor Laura Gaspari. And I would like to thank to Professor Andrea Genersani for this invitation. I share my screen. The topic, as mentioned, Professor Sultan, is contraception in the adolescent. And the goals is present a description and rationale for best practices in counseling and prescribing contraception for adolescents. This is my agenda. And I would like to show was the worldwide are unwanted pregnancies, unwanted, as you can see in America, unwanted pregnancy is higher, especially in the Latin America and the Caribbean area. And you can see compared with Europe, Africa, Asia, and others. This is the worldwide is unwanted 40%, unwanted 60%. The rate of unwanted pregnancy is higher in young women. Young women experience the highest percentage of unintended pregnancies. For example, 69, it's occurred in a single woman with between 20 to 29 years old in United States, 16 in United Kingdom, 45 in German, and 81, for example, in Brazil. Even when in Mexico is higher, the percentage, as I presented more late. Unwanted pregnancy imposes a personal and health system burden. An abortion can have consequences, medical, psychological, and emotional. Births resulting from an unwanted pregnancy negatively impacts the mother. About health system increase in costs associated with induced abortion, post-abortion, care, prenatal care, childbirth care, and postnatal care. As you can see in this chart, consequences of unplanned pregnancy, for example, in United States, in Europe, you can see the spontaneous abortion is 11%, but induced abortion is 25%. But for example, in Latin America is higher than others, 45% of induced abortion, and spontaneous abortion is 13, is almost the 50%, and other areas like North America, Africa, and Asia. What about adolescents and pregnancy? In the last years of adolescence, approximately 60% of adolescents have had sexual relations. And in this chart is divided by age, in blue light, 15 years, in purple, 18, and in green, 28. And you can see as the North countries like Finland and Sweden, and others like United States, United Kingdom, and Canada have different percentage. But for example, in Finland, Sweden, and United States, the 15 years have had sexual relations. This is another scenario in which it's important to put what happened in Latin America. As you can see, Venezuela has the higher percentage, followed by Colombia, Mexico, Argentina, and Brazil. And if you compare this percentage for 1,000 adolescents, for example, it's only 10 in Germany, and in France, only 11. This is the most recent data from Mexico to 2018, in which mothers that 20 years age or more represent 81.5%, and mothers in the adolescent to 10 to 19 years represent almost 19%. And this is a splendid paper by Joel Rai. It was published last week, in which teen pregnancy and risk of premature mortality. And I would like to mention exposure, then pregnancy at 12 to 19, if you put in no pregnancy, is 1 to reference, but HR ratio is higher when a teen has 1 pregnant, but is even more higher. You can see on adjusted hazard ratio 2.4 when there has more than 2 or 2 pregnancies. The other compare is the by age range like this, to 12 to 50 is 2.3, to 16 to 17, 1.9, and final to 8 to 90, 1.7. Among these, when teen pregnancy, no injury related premature mortality was more common. The causes, almost 50% occurs due to inconsistent use of contraceptive method. And in this paper published in the Journal of Adolescent Health by SEC, although abortion and childbirth rates are decreasing in adolescents, they remain high. As I mentioned, in United States, abortion has a higher proportion in New Zealand, England, and Sweden too. Compare, for example, with other countries like Singapore, that is less. And especially the challenges of contraception in Mexico and Latin America, adolescent reproductive health global overview, no sexual activity, 44 in Latin America, when you put the range less than 20 years, and in developed countries, 23, the first sexual intercourse represent 56%, I remark, less than 20 years, and in developed countries, 77. It's important to mention that a child is higher in Latin America, the double than in developed countries, as you can see. Regarding the strategies to reduce the number of pregnancy, using a structured type of interview can help create a positive counseling experience. The Global Care Group used the acronym GRADER. And GATHER is greet, ask, tell, help, explain, and reassure. And it's important, know your reproductive goals and values, discuss contraceptive efficacy and failure rate, both in typical use and correct use, broadly explain the potential adverse effects and risks of the method, describe the easy to use and no contraceptive advantages, explain how barrier methods are used to reduce the risk of sexually transmitted diseases, and ability to decline or continue any method. This is important to mention that adolescence has hormonophobia. It's a phenomenon perpetuated by the media, friends, and family. And it's important to to mention that this don't happen. This is a very interesting paper by the group from Stella Julian in Germany. What about the source of information? As you can see, gynecologists have the more frequency percentage about the information. Second is friends and family, school and university, internet and social media, books and paper, and others. And I put here that the responsibility to the physician, especially the gynecologist, to inform to adolescents about contraceptive methods. Another question was, would you recommend your daughter to take the pill if she was in the appropriate age now? Rather yes or rather no. That is important that rather no mention 816 twice. And the other is reinforce counseling not only by health personnel. The perception and rationale for perception, frequency, and proportion. And as I am currently thinking about stopping, changing to another method because I no longer need to prevent pregnancy. I am experiencing side effects. That is and the other is I am worried about the long-term effects. That this is necessary that the health personnel reinforce. Finally, rationale for discontinuation of oral contraception. And as you can see in the green area, hormones, I wanted to get to know my body independently from the influence of artificial hormones that mention 25%. About contraceptive methods, this is the global data by region from 1995 to 2020. And it's important to mention, for example, in Mexico, it's very common the sterilization, but if you can see, for example, Spain or Italy, in which the adolescent use two methods, or for example, the pill in other areas, especially in South America and Brazil. And I would like to take this fantastic paper about contraceptive choices for young people, in which UK medical eligibility criteria for contraceptive use, as mentioned that UK MEC, and for example, by age, combined hormonal contraceptive used from menarche to more than 40 years, and the UK MEC category is 1 to 2. For a progestin-only pill is 1, progestin-only implant is 1, progestin-only injectable, medroxyprogesterone acetate depot, or nortestosterone enanthate from menarche less than 18 that use classification 2. varied methods, but the most important is the intrauterine devices and levonorgestrel intrauterine system, especially in this age, is very important, as I mentioned more late. I would like to show you effectiveness of contraceptive method during the first year. This is the low efficacy, like spermicides, female condom, for example, male condom, with high effectiveness and used correctly, vaginal ring, patch, progestin-only pill, combined pill, and injection. In the bar in blue light, if used correctly, and in bar in red color as commonly used. And final, the very high efficacy like intrauterine device, intrauterine levonorgestrel system, or implant. In order to contraceptive methods about efficacy from left to right, this is the methods that has less efficacy, followed by the hormonal, like combined hormonal contraceptive, vaginal ring, patch, pill, extended use, progestin-only pill, pill with combined oral contraceptive, injection in green, and the most effective, like intrauterine device, levonorgestrel intrauterine system, implant, is compared, for example, to vasectomy or sterilization surgery in women. I would like to mention what women want from their oral contraceptive. First, they want efficacy. Second, safety. Absence of size effect. Absence of body weight gain. Favorable effects on the skin. Positive influence on mood and quality life. Reduction of symptoms during hormone-free days. And possibility of controlling menstrual cycle, duration, number, and amount bleeding. Oral contraceptives have a viral rate less than 1%. This is the typical use in blue and the perfect use in green. This is for oral contraceptive that I mentioned. Efficacy with perfect use when used with 100% accuracy without reliance on self-administration and used exactly according to the instructions. And this is the different regimens and description. The conventional, 21-7, conventional hormone-free period, 24-4 or 26-2, extended hormones for more than 28 days, followed by hormone-free interval, and continuous, that is regimen used for 90 days. It's important to mention that, for example, in adolescents that present heavy menstrual bleeding, one of the best options in oral route is the combination of valerate estradiol plus digenogest, and you can see measure blood loss, and the other, the sanitary protection, in which is there are a reduction in use the sanitary protections. Other examples in combined oral contraceptives is to do a specific pharmacology tailored to women's health. For example, when adolescents have normal weight or overweight or underweight, especially in adolescents, to use ethinyl estradiol 15 to 20 micrograms with a neutral progestin. In overweight patients, you can use antiandrogenic progestin, or in underweight, use a higher dose of ethinyl estradiol, 20 micrograms with neutral progestin, or a meal antiandrogenic. If you compare with fertility age or the perimenopausal, you compare the different dose and type of progestin. This is the more recent paper by Dan Apter, in which use drospirenone 4 milligrams in adolescents with 7 cycles, and drospirenone only pill reduction of dysmenorrhea in adolescents. You can see in green mild, in yellow moderate, and in red severe, the intensity of dysmenorrhea after 6 cycles and after 1 year. Regarding the same topic, this is another paper by Andrea James for gynecology management of heavy menstrual bleeding in adolescents who have bleeding disorders. You can use a combined hormonal contraceptive that reduce menstrual blood loss, even in patients who has von Willebrand disease. Levonorgestrel intrauterine system, that this is effective at reducing menstrual blood loss, and medroxyprosterone acetate injections and pills should also reduce endometrial proliferation and reduce menstrual blood loss. It's important to mention what is the risk about venous thromboembolism, and this type of combined hormonal contraceptive use. Women that not use it, the risk of developing VTE in a year incidence for 10,000 is 2. And when used combined hormonal contraceptive with levonorgestrel, norethistérone, or norgestimate is 5 to 7. When using etonorgestrel or norelgestromin, 6 to 12. And finally, with combined hormonal contraceptive with drospirenone, gestodin, and desogestrel is 9 to 12. I take in advance these 2 wonderful papers. One is by Jürgen Dinger, is the INAS score study with more than 50,000 users. And the conclusion is that Dienogest plus estradiol associate with similar to lower cardiovascular risk. And the other is this study by Susan Reed. The name is the Pro estradiol study with more than 100,000, in which use almost 50,000 with NOMAC plus estradiol user, and it compared to levonorgestrel user progestin of 2nd generation. The continued rate of contraceptive methods during the first years of use is higher, for example, for LARCs to levonorgestrel intrauterine system, intrauterine device or implant, and implant almost 80%, and another like a patch, combined oral contraceptive is less the percentage. This is a very interesting paper that the name is Choice Project. It's a prospective core study in adolescents and women to 14 to 45 years of age. Average was 25 years who decide reversible contraception, almost 10,000 patients, and 84% were recruited from universities or community clinics. 60% were recruited from abortion clinicians. All women received contraceptive counseling and all reversible contraceptive methods, including LARCs, and this is the result. For example, in this pie chart, the no long acting 23%, but for example, 75% of methods that adolescent selection was implant, intrauterine device, and levonorgestrel intrauterine system. 67 of women chose LAC, 56 they choose intrauterine contraception, 11 subdermal implant, and the levonorgestrel intrauterine system was the most chosen contraceptive. About this topic, this paper by Mario Philip Festin that represent the most effective methods, reversible, implant, intrauterine device, and levonorgestrel intrauterine system is compared to permanent male or female sterilization. 6 to 12 pregnancy represent pill, patch, ring, even diaphragm. And the less effective with 18 or more pregnancies for 100 women in a year, all like female condom, a sponge, and spermicides. About the most important, this is a fantastic paper published in Contraception in 2022 that extended use of long-acting reversible contraception. One is the levonorgestrel intrauterine system with 52 milligrams approved by FDA for 7 to 8 years. And in last year, ACOT published in 2022 that the effect is for 8 years. Implant with etonorgestrel, 68 milligrams, FDA approved for 5 years. And finally, the intrauterine U 380 approved duration for 2 to 12 years. I would like to mention that there are different papers, especially this by Christina Gemsel, that published about levonorgestrel 19.5 milligrams in data for phase 3. And you can see the year by 5 years, for example, and the exposition is a very high number, and the Pearl index was was very good result with 0.29. Its effectiveness is maintained over the time. But I would like to show you another paper from Dieter that takes some data by Luis Bajomondes that study 776 women in Brazil, and the first number was 116 and follow up during 7 to 15 years, then 17 to used to 12 to 13 years, 31 used during 10 to 11 years, and almost 100 patients used 8 to 9 years. And finally, a small number used during 14 to 15 years. 75 of this group presented amenorrhea. More recently, Jeffrey Jensen from Portland, Oregon, published the extension use of levonorgestrel intrauterine system with 52 milligrams in patients to 18 to 35 years. To a number of patients was 362 during 6 years, 2,093 during 7 years, and 2,029 during 8 years. My conclusions is pregnancy at early age is considered a public health problem because it carries higher risk of complication. The average age of beginning of sexual life is 16 years. 4 of 10 adolescents between 15 to 19 years of age are sexually active. And the most important is the lags are very effectiveness. Every woman is different. Every woman in the adolescent need to be studied and remark some considerable consoling. Thank you very much.
Thank you, Professor González, for this interesting talk. And now both presentations are open for discussion. Regarding the first topic, adolescent dysmenorrhea and endometriosis, we have already some questions. So I will propose Dr. Gaspari to answer the first question dealing with dysmenorrhea or endometriosis, and then to move to Professor González. Do you agree, Professor González?
Yeah.
You agree with me? We start with the discussion related to dysmenorrhea and endometriosis, and then move to your talk.
Yes,
Okay?
Professor. Yes, okay.
Okay, Laura, can you read the question you received?
Okay.
Please read the question.
Alors, the first question I received, it was about anti-inflammatory medication 1 or 2 days before expected menstruation, not more effective, especially with in no regular cycles. In my experience, yes, it is. It may be more effective, because it reduced the quantity of inflammatory signals.
Very good question.
The second is, surely a hormonal contraceptive pill can only be effective if taken continuously. so that menstruation is completely suppressed. Yes, but sometimes with a contraceptive pill take continuously, some adolescents may present spotting and irregular bleeding, and so we give like advice to stop to take 3 or 4 pill, how to say, 4 months continuously to take to perform a stop and to start again for 3 or 4 months to avoid this spotting, and I think it's a good way. Ora González asks, what is your opinion in drospirenone 4 milligram in adolescents who require contraception? Drospirenone is it is a progestative, so it is useful for endometriosis, I agree, but we have to look for side effects, for psychological effect like depression, and for bone body mass effect on body mass or bone mass.
Dr. González, if you have a comment, please, you can give your feeling, your.
Yes, I think the adolescents can use those non-only pill. In the paper, especially in the paper of Dan After that study 170 patients, the result was very good and don't have any disadvantages. I think it's a good option for adolescent people, but I prefer to be consoling in large methods.
Thank you.
Okay.
Next question.
Next question. What is the diet we advise for endometriotic patient? A lot of paper put the attention on the effect, the good effect of a Mediterranean diet. So with a low amount of fat, especially of the transformed meats and transformed food. Donc, so for this reason is better.
I think the main link between the diet and dysmenorrhea is known to be through the obese consequence of diet, since obesity is usually associated with hyperestrogenism, which increase the prevalence and the intensity of dysmenorrhea. But there is no, as far as I know, a direct link between diet and dysmenorrhea. This is my opinion.
In any case, endometriosis is an inflammatory disease. So if you use an anti-inflammatory diet, like a Mediterranean diet, it's usually better. And how many patients present coexistence with a functional colon? A lot. In our experience, more or less the 50% of our patients present a functional colonopathy as diarrhea, irritatory colon syndrome, but we have to exclude posterior deep infiltrative endometriosis or adenomyosis. So in this case, ERM, please, or MRI, or please, if the adolescent agree, we can perform a transrectal echography to put diagnosis. Another question is, there are any study or guidelines regarding the use of Agnus castus or magnesium, other supplement for dysmenorrhea? Sometimes mothers do not want their teen daughters to take many medications, so they use alternative natural selection. I think that we have two problems: a chronic problem and an acute problem. We have to avoid this deregulation of of donc peripheral and central sensitization will start. For this reason, I conseil to family to start with a normal pharmacological drug treatment with anti-inflammatory to give an immediately bien-être, how to say, well-being to our adolescents. At the same time, yes, we have to give advice regarding magnesium. Magnesium, more annus castus, is really effective, and exercise, acupuncture. There is a Cochrane, and quite recent Cochrane regarding exercise and acupuncture. So there is some publication regarding this. But please, for working these acupuncture or alternative drugs are a little bit long to work. So it's better to add them to anti-inflammatory drugs.
If I may add something, at least in France and in maybe some European countries, it's become fashionable to avoid pharmacological treatment for treating especially adolescent dysmenorrhea. And a recent analysis revealed that 52% of adolescents adopted non-pharmacological measures to cope with their menstrual pain. So we do have some result in some cases, but in my opinion, this should not be the basis of the treatment of adolescent gynecology. Yes, it does work. There are some alternative treatments who are efficient: acupuncture, acupressure, nerve stimulation, transelectricity, and so on and so on. But the basic treatment is hormonal therapy and non-steroidal anti-inflammatory. Even if it's very fashionable, don't miss efficiency to avoid a drug. Please.
Another question is, how is the management of endometriosis in adolescents who are resistant to OCP? After OCP, we can use progestative, and after we can go where analogs, generation analog, to try. And I don't know if González, Monsieur Professor Celis, what do you think about
the use of hormonal contraceptives?
For adolescents that doesn't respond to endometriosis, to OCP, we can use a progestative and after generate analog. It's what we do in our experience.
No, I prefer to use combined oral contraceptive, especially the combinations, the pill that with the Gynogest, because it's more effective to suppress the endometrium.
And if it doesn't work?
It doesn't work? Probably use only Gynogest with 2 milligrams, but it's necessary to protect with another contraceptive. If it is adolescent, for example, with condom or another method special to combine 2.
Okay, thank you. So we have answered both to Eka. And Eka also asked, do you have any experience with probiotic to decrease the symptom of endometriosis in adolescents? How is the effectivity? I'm sorry, but I have no experience on probiotic. I'm sorry.
No, I don't have experience even with probiotic. I think that the results in endometriosis is not good.
Yeah.
There are some questions for you.
If you can.
You-
Can you answer to the question raised by attendant, please?
Yes. Okay. In patients with intellectual disability who have had an intrauterine device, Mirena, placed with a suppressive effect, with the information that internal contraception, its effectiveness has been extended, yet would you like to apply equally to this patient? Yes, of course. In patients with disability, you need to reinforce and to explain very well. And this is a very good opportunity to use when in this kind of patients that has disabilities. I think Mirena is a good option, even Kailina that has 19.5 milligrams, and this is more small for these patients.
What is the earliest age to start OCP, and what about the maturity of the hypothalamic pituitary axis?
It's a question for you, Celis.
Let me check. What is the earliest age
Yes,
to start? Okay.
yes, it's for you.
Yeah. I think all the guys mentioned that you start to use any combined oral contraceptive when patients start to have sexual relations. It's independent of the age is necessary. This is the reason that, for example, in Mexico, as I can show, the pregnant in adolescent is higher, more higher than I suppose now, more than in Brazil and in Colombia.
So I would like to make two comments. The first one, we know that puberty and ovulatory cycle start earlier than before. My question is, don't you think that we should think about starting contraception earlier than before? This is the first. And the second, now I'm retired, but during my clinical experience, I met hundreds of very young adolescents who look and who need for contraception just few years after menarche. So do you have the same experience in Mexico? Do puberty and ovulatory cycles start earlier? And should it not be necessary to start contraception earlier subsequently? What do you think about this point?
It depends, because if patient needs to be protected, you need to offer the best option that you have in your clinical or special in government areas in the system of health here in Mexico. It use very often the intrauterine device with copper 318 is very common to use. And the other, probably, especially in health system, is to use the pot medroxyprogesterone acetate, 150 milligrams every 3 months.
Okay, I will come back later on this specific aspect. You have other questions, Celis, if you want to answer the question that raised by participant. There is a question from Michelle Moreau. Can you read? Okay.
For how long it is effective? For now, the FDA approved for 8 years. But I show the work from Baumondes from Brazil that used for more years, even when levonorgestrel don't put. Do you remember that when many years ago, doctors put the asa de lipase, that this is only the plastic that produce inflammatory reaction. But I think that that the specification currently is during 8 years. This is for adolescents. It changed some in, for example, in the menopausal transition. If you put, for example, intrauterine levonorgestrel system at age of 45, for example, you can live during more than 10 years because you only need 80 micrograms to protect the endometrium. But this is another case only in the transition to menopause.
Okay, let's come back to the contraceptive option. And I would like to point it out that in a recent kind of consensus meeting, it appears that long-active reversible contraception was considered as the gold standard for adolescent contraception. What do you think about this?
The gold standard?
Yes, for adolescent contraception was long-active reversible contraception. I'm talking about copper IUD and levonorgestrel IUD. What's your feeling?
My feeling
It's not
is,
my opinion. It's appealed from a consensus meeting.
Yes, of course. I think is the patient don't have heavy menstrual bleeding, you can use an intrauterine device. But it's a good option and is the indicate for heavy menstrual bleeding to put a levonorgestrel intrauterine system.
Okay.
I think that I decide in these two situations, if the patient have normal bleeding every month or if the patient have heavy menstrual bleeding.
Thank you. The next question is for Laura.
Endotest, a new test from saliva for endometriosis. Any feedback, please? As far as I know, or publication regarding adults around 30 years old. So I think that it could be the future for us to make early diagnosis. But I think that we have to wait a little bit for that this kind of test will be perfect also for teenagers.
Very good question. We are looking for data in adolescents, but it's a very good point. Thank you, Kinda. Thank you, Kinda.
Now is, do you think that there is an autoimmune etiology of endometriosis? I think that there is a link between endometriosis and autoimmune disease. Since many women with endometriosis develop after autoimmune etiology, autoimmune disease, but the autoimmune etiology is not confirmed of endometriosis.
You know, endometriosis, in my opinion, we study a lot this disease. It should be considered as a multifactorial disease. And there are some specific factors, some very early factors, some environmental co-factors. So it's, in my, maybe I'm wrong, but it's not a single cause disease. Next question is for you, Celis.
Yeah, what are the
choices?
I think I love, for example, the NOGs combined with estradiol valorate, because in the scheme is 26 and only have 2 days free interval. And all the papers, and I think the interval-free pills produce more cephalea, pelvic pain, and another symptomatologies in this period in which, for example, in the scheme to 21 to 7 days of free interval. This is the reason that I prefer 26.2 or 24.4. It depends, but I would like more the NOJS. I would like drospirenone too, but I love to levonorgestrel too combined with ethinyl estradiol. And you can do the scheme wherever you want, even when, for example, in Mexico, there exists only the presentation with 21 pills with 7 days free, but it depends.
Okay, a very short question, and please, short response. Do you require parental authorization to use long-active reverse contraception in teenagers? Yes or not?
Here in Mexico, the laws permit to use without authorization of the parents.
Okay, thank you. Next question. It's for whom?
Over 45, not responding to survey, just only Mirena and have migraine, can use implant, can she?
This is for you.
Yes, it's not a teenager. I'm sorry.
It's for you.
Yeah, but I think the migraine is not a contraindication. The MEC, the eligibility criteria for OMS permit to use in the classification 1. Is no problem with migraine.
Do you need to consider the TLH stage in adolescent girl before starting her on OCP?
I don't know. I would like more to answer Professor Sultan about this question.
This is another candid question, because breast development, it's a very specific condition. There are some girls who have menarche with a very low breast development. So breast development, it's specific to each adolescent or peripubertal girl. It doesn't mean anything. So we should consider the age of menarche rather than the level of breast development. I hope I am clear. In some countries, such as in France, girls have a very important breast development. And in Northern Europe, they are a lower stage of development, of breast development. So it doesn't mean that your pubertal development is more or less start. It has more or less start. It's nothing. It's menarche, which is the main point. Other question?
How we can manage the unintended bleeding with implants?
Oh, this is
okay. You need to only talk about counseling, because even when you use any kind of medication, don't function well. But the guy mentioned, if the possibility that the patient's compliance with the method, you use anti-inflammatory non-steroidal for 5 days, as you mentioned in your talk, Laura. And this is the main point in patients who has unintended bleeding with the implant, especially with Norplant.
Okay. Next question. Can you read?
According to your opinion about the long medical treatment of endometriosis with Denogest, start from the third cycle, some of the patients should from what is the next solution for the patient?
Difficult. Question is not very clear. I'm sorry.
Albi?
I suppose mention about abnormal uterine bleeding that use Dianoges for 3 cycles. What do you think about this? I suppose this is the question, Laura.
It's a question to you, Celis, not to Laura.
No, but it's for also for treatment. I think it's the same things.
Yeah, the treatment endometriosis.
Yes. But,
I suppose I ask a personal, what is your experience with Dianoges only with 2 milligrams in patients with endometriosis? When do you use?
I usually use OCP, and we use Dianogest only with girls that don't respond to OCP continuously, and we sometimes we can use it for three or 4 cycles, so we can stop a little and we start again. We try to use it more than we can, and it's the adolescent who told us have this problem, and we will try to find a solution.
The next question. Oh, it's for you, Celis. The next one.
It's okay. The desogestrel is a comment in the last commentary, but now it's migraine without an adolescent, a contraindication of OCP. Yes, this is a contraindication. The principal use in classification is to use progestin only pill. You can use desogestrel or the new drospirenone only pill with 4 milligrams.
Thank you, Dr. Sultan, on the comment.
It's not a question, it's a comment.
What is the best choice of progestin that you have already answered? Does Dr. Celis, Professor Celis, comment on which one is superior, if there is one?
Do you want to make a comment, Celis?
Yeah, well, I am thinking, I insist that I like Dianoges, combined oral contraceptive pill with valorate estradiol, or it depends with ethinyl estradiol. But in Mexico, for example, Dianoges with ethinyl estradiol, this is only in the scheme 21-7.
There is a difficult question for you, Celis. Is migraine with oral in adolescent contraindicating to OCP?
Yeah, I respond in the last comment, but I mention again about the use only progestin only pills.
Okay.
So we have finished the question.
Just before we leave Celis, I would like not as a take-home message, but I would like to come back to the supposed side effect of contraception, because it's a very frequent point raised by our adolescents. So the question, could you answer yes or no? Any side effects? First, on weight gain, I'm talking about oral contraception. On weight gain, yes or not?
No. This is a how do you say it is a very common thing that people think that pills increase the weight, but
I know, I'm asking you, the expert.
yeah, no, it's all the papers that show that contraceptive, all contraceptive, only contraceptive pills, combined contraceptive pill, don't increase the weight.
Okay.
Probably the unique is the pot medroxyprogesterone acetate.
Okay, but it's not used everywhere. For
Yeah.
instance, in France, we don't use. Okay, any impact on mood?
Impact on mood. Oh.
Yes or not?
I think it's common to mention too, but it's no real data in the papers.
Okay. Any impact on bone mineral density? Yes or not?
Yes, but this is improved. Less, but improved. Or specific when you combine progestin and estrogen. And if you have more dose of estrogen, for example, ethinyl estradiol for 30 micrograms is better than 20.
Okay. And a last question to Laura. What is the true prevalence of adolescent endometriosis? Because there are very conflicting data. Laura, can you answer this point? It's not a candid question.
Thank you so much. I have not heard it. I'm sorry, I have some problem. It's very difficult to answer because as dysmenorrhea, not all girls with endometriosis come to gynecologists, to doctors, so it's very difficult to answer. I will do it in 10 years.
Can I add also something? I was here with you.
Oh, thank you.
Yes, and I would like to add something related to the mood changes. This is a very important question. There are individuals who have where you can have some depressive symptoms starting just when she starts the beginning of contraceptive use. In these cases, you have to change the progesterone. You have immediately to shift the patient to another one because there are two main reasons. One is that in some individuals, the different progesterone can inhibit the endogenous production of allopregnanolone from progesterone. And then, as you know, allopregnanolone is the most important antidepressive and defensive endogenous neurosteroids. And this cannot happen in everybody in the same way, but there are some individuals who have a specific vulnerability. Then you have to change the family of the progesterone. And you have to go to a progesterone who don't impact allopregnanolone production. And this is the first question. And also, I think this is very individual. Then once that you change the progestin family, normally the subject have no more depressive symptoms. And then you have no more this, which can be considered a risk factor for the young. Sorry.
Thank you, Andrea. Very useful comment.
Thank you.
And if we don't, I think we have to stop according to the schedule. And just before, I would like to thank again Professor Gynecology, and on behalf the several hundred of participants, to thank the speaker, Professor Celis González from Mexico, and Dr. Laura Gaspari from Montpellier, for having shared their experience with us. And maybe I just want to remind you that there are a lot of webinars organized by Professor Gynecology, and I'm sure that we will meet in one of these future symposiums, and for us, for both of us, mainly dedicated to adolescent gynecology, since you understood that it's our field of clinical research, epidemiological study, and so on. And I am sure also that we all meet in the next ESG Congress in Florence, which is the gold standard for for gynecological and endocrinology in the world, is the most important, and for us is really the gold standard you can miss if you want to be aware of the new developments, the new concept, the best treatment, and all the recent data which appeared during the last 2 years in this field. Thank you, Professor Gennazani. Thank you, Professor González. Thank you, Dr. Gaspari. And maybe in the rendezvous in the next meeting. Thank you.
Thank you. Thank you very much, Professor Sultan and Laura. Professor Gennazani, thank you very much.
Thank you so much.
It's my pleasure also to invite you to join the 21 of March, the next Thursday, to the next webinar, which will be in Spanish, Aspectos Prevalentes en la Mujer en su Mediana Edad, que va a ser a las 9 de la tarde, hora de Buenos Aires. Hasta pronto.
Adiós.
Adiós, arrivederci.